All right, so this is the last question that we looked at yesterday, talking about medication administration and the process for that. And given your choices, what were the correct steps then? Okay, and what was the answer? You guys remember? So you can rip off your name tags now and use your markers. What was the order? Yeah. No, not C.
What?
Not C. It's not C.
D? No, I'm on
C. Okay, so this one is B. Okay, the only one that's right here is B. Okay, we're gonna scan the patient, right? So we're on to the third check now, right? This question in this scenario, we've done the first and second check. So we're in the room, we go to the computer, we go to the MAR, and when you go to the MAR, if you look at it, it says in red letters, not scanned, when you get there. Okay, and then when you scan your patient, to make sure you're with the right patient, it'll turn green, it'll say patient scan. Okay, so you know you're with the right patient. Okay, so you'll scan them, then you're locked in, right patient, any drugs that you scan from that point, if they're not due for that patient at that time, it will tell you, and you shouldn't be able to give them. Okay, if you don't use your barcode scanner and you don't look at anything, you could just walk in and give them anything and walk back out. Okay, but that's not how we do it. So we scan the patient, so we're locked in for them. We scan the drugs, maybe there's one, maybe there's 20. We scan them all, and they're all queued up on the screen. After they're all scanned, then we turn to the patient, if we haven't already, and we say, these are all the drugs I have, this is everything that we're gonna do, and then you give them. Once they're swallowed, injected, applied, whatever it is, you go back to your computer, you hit accept, it'll take your fingerprint, and then your documentation is complete. All right, one more question from that content, and then we'll move on and talk about the parts of an order. Okay, good. So specifically, we talked about pain or cardiovascular medications. Now, like I said, anytime you're giving a medication, that should never be the first time that you're seeing your patient or thinking about your patient. You should have vitals, a head-to-toe assessment, you should have done your patient research, so you have an idea of what's going on with them. But when we're giving pain or cardiovascular medications, there's specific documentation that has to be done, timed along with the administration of that. Okay, so usually it's blood pressure, sometimes heart rate as well. Okay, and then for pain, it's our pain scale. And then usually a respiratory rate too. All right, so trying to reduce the risk of an error or a mistake happening when we're giving our patients medications. So we're gonna talk about prescriptions, so what all has to be involved for a prescription to be complete, the medication reconciliation process, and then if there is a medication error, what would have to be done for that. All right, so here's an example then of the parts of an order. So off to the side here, if you look, that's kind of like what you would see on a prescription pad. So there's your patient's name and your patient's date of birth. Sometimes that'll be handwritten. Oftentimes you have a patient sticker, right? In your facility, you print off a page of stickers. It's got their name and date of birth, also their medical record number. Okay, but for an order, it has to be name and date of birth. So it'll either be written or they'll have that sticker. And then today's date and time, whenever the provider wrote that order, the name of the drug, the dose of the drug, the route of the drug, and the frequency of the drug, which is different. It's a little bit different from our checks because we're concerned with time, right? We need to know, am I giving it now or am I not giving it now? Whereas for the order has to have the frequency. How often does it need to be administered? okay? And then the reason or indication, and then that provider's signature. Okay, so if they're handwriting a prescription, it could be, a handwritten signature, maybe they have a stamp that they used. Okay, so that's what it looks like if they're handwriting a prescription. In the electronic health record, it's all electronic. So as they go to put in an order to do patient's name and date of birth, they just open up that patient's chart. Okay, so if they open up that chart, they're in the right patient. They go to the order entry page where you put in orders. As they fill out that order and complete it, time and date stamps it. So they don't have to say this is the date, this is the time. The computer does that for them. So they just choose the drug, they choose the dose and the route, and then the frequency. They should indicate the reason. You don't always see that, but we like to see that because it's easy, makes our job easier, right? If everybody knows why we're taking a medication. Sometimes it's obvious, other times it's not obvious, and you have to do some digging to figure out why are they taking this. Okay, and then as they complete that, it'll lock in their electronic signature. Okay, so those are the parts of a prescription, so all of that has to be complete. If you're using the technology like it's supposed to be used, we don't have to double check these things because the system won't let them miss anything. So by the time it gets to us, we can be sure that it's complete. If you're maybe working in a nursing home and working with handwritten orders, or if you're in a position where you're even taking a verbal order for a doctor, which you shouldn't do, you might miss part of it. So you need to know what are all the parts to make it complete. Okay, so the drug, the dose, the route, the frequency, all of that is indicated by the provider. That's never something that we can change. We can't change the name of the drug or the type of the drug, the amount, the frequency, the route. We cannot change any of that. That's all part of the order. All right, and then I have several questions here with examples for you to practice to see if you can spot this, what would be missing. Okay, so we've got an order up there for Tylenol, 650 milligrams by mouth every 6 hours for fever, date and time, and the doctor's signature. What part is missing? Good. And we don't know who it's for. Okay, we need the patient's name, and then that second identifier, their date of birth. Who is this for? Okay, good. You go through, you can see that there's no date and time, so we don't know when this order was written, when it's for. Okay, so heparin is a drug that's very similar to our enoxaparin or Lovenox. So what's enoxaparin or Lovenox? What is that? Enoxaparin or Lovenox? You're not wrong for your heart. What drug class is that? Yeah, it's an anticoagulant, okay, which is another way of saying a blood thinner, okay, and it's a sub-Q shot. So we're gonna talk about how to give sub-Q shots. So after you have your checkoff for oral and topical medications, then you'll have your injection checkoff. So heparin is just like Lovenox, very similar. It's a blood thinner. It also is sub-Q. Heparin or Lovenox comes in milligrams, like we're used to. Heparin comes in units. Okay, so it's just the unit of measurement. So it would say something like 5,000 units per ml. So you would give 1 milliliter if that was the order. Okay? So units, same thing as like milligrams, micrograms, milliequivalents for potassium we see. Okay, so it's just how it's measured. Okay, so we've got all of the information, but we don't know what we're giving, what drug. Okay, so that is gonna be C, the name of the drug. up as part of the order, so we have to get clarification on that. Okay, good. So we have the patient's name and date of birth, date and time, drug, dose, route, frequency, indication, but there's no provider signature. Okay, looks like B, so we have a date and time, we have a drug, dose, a route, an indication, a signature, but not a patient name or date of birth. All right, so that's the parts of the order, so we have to be able to identify if it's complete. There's some different types of order in clinical. You may have talked about these a little bit already. So a standing order is just like a basic order. It could have an end date or maybe not have an end date. Common medications that do have an end date would be an antibiotic. So that would be prescribed, so like your cephalexin or your Keflex up there, 500 milligrams by mouth, every 6 hours times 7 days. Okay, so that would be mapped out then, and it would be discontinued after that 7th day would be done. Okay, or standing order, like our digoxin or Lanoxin, 0.5 milligrams by mouth every day, and there's no stop date for that. They just take it continuously. Okay, they follow up with their provider every 3, 6 months, or whatever it might be, and they would determine if they would need to continue it or not. Okay, so those are standing orders, and then PRN or the as needed orders. Okay, so those aren't just given automatically, they're set parameters and indications. Common reasons are pain, nausea, and sleep. So we would have to assess for those things, and then if they're having those things and it's indicated, as long as the timing is okay, then we can give it. This example here is actually one that you don't see as much of, because it can be a little bit dangerous because there's a range in here. So it kind of leaves a lot to chance and interpretation. More likely now, you would see something like morphine 2 milligrams for pain up to 5, and then morphine 4 milligrams for pain of 6 to 10. So it would be more specific. And then every 4 hours. So if your patient, what time is it? 10:20. So if your patient maybe had something, if they had this morphine at 8 a.m. for their pain, and then they asked you, I'm having pain, can I have it again now? We wouldn't be able to give them this morphine from this order because it hasn't been 4 hours yet. So if they have a different medication or a different order for pain, maybe we can give them something different. Or maybe we have to try some non-pharmacological interventions. Or if it's really bad breakthrough pain, we'd have to get a hold of the provider and see if there's something extra that we can give them. Okay, so PRN, it's as needed, we have to assess for it, we have some documentation that goes along with it. And then it's important to let your patient know how often they can have it. A lot of times you'll see it written on their whiteboards in their room, like this is the last time you had it, this is when you can have it again. And again, while we're talking about pain medicine, so we're always on the lookout for like overdose. We want to keep our patients safe and alive and breathing, but then also just make sure that you're on the lookout for inadequate pain control. So patients who are in pain and are afraid to ask for anything. So make sure we're assessing for that. And then sometimes you'll have one-time medications that they're ordered, and then once they're administered, they'll fall off the MAR and they'll go into like the discontinued column. They won't be active anymore. And then a common one, if you work in the hospital on med-surg and you have patients who go into OR, they'll have like one-time doses of things just specifically for pre-op, like atropine is a drug. It dries up your secretions, so you're less likely to aspirate when you're intubated. So that would be a one-time dose. Okay, and then a stat is immediately. So like morphine 4 milligrams IV stat, it would be something that should be like on your system, would notify and alarm you that you have a stat drug that was ordered that needs to be given right away. Okay, and then protocol drugs, we're seeing a little bit more, which is really great because it used to be like a whole big game of phone tag in the morning. You'd get there and you'd look at your patient's labs, and then you'd have to reach out to the provider and wait for him to call you back, and then they'd have to look at them and decide what to order. Whereas some places that use protocol now, when labs are drawn at like 5 a.m. or whatever it is, it goes into the system and they'll have protocol orders based on what their lab values are. Then pharmacy will automatically put in an order for replacement. So like with your potassium or magnesium are common ones that will see that. So you could have protocol orders for electrolyte replacement, which is nice. All right, medication reconciliation, I mentioned a little bit yesterday. So that's a process that the provider does, and we also do, but the provider is the one who orders medication. So the responsibility to do it is on them. A lot of times it's on us, like as we're going through our checklist to make sure it was done, so then we're like reminding the provider, you have to do your med rec. Okay, but it just means going through a list of what they take and making sure it's accurate and up to date. Okay, so like we said, it's very seldom that you'll have a patient who's brand new to your system. Usually they're in and out, they've been there before, so you should have in your system a list. It's just a matter of going through it with your patient, or if they have a family member or whatever, and going through each one and saying, this is what we have, is this correct? Is this what you're taking, or is there any change to it? So when they're admitted, that's part of the admission process as we go through every single one and compare. MedRec is also required during any transfer. So like if your patient goes bad and is transferred from med-surg to ICU, that provider is required to do a MedRec to go through all of those and reassess. Same thing, like if they're in the ICU and they get better and then they go to med-surg, the provider has to do a medication reconciliation and go through everything and make sure it's appropriate. Another time then is when they're discharged or like transferred to a nursing home, they have to do a medication reconciliation, go through every single one, say yes, continue, or stop, or add new, or change, so everything is safe and up to date. And then usually when your patient is discharged, after that process is done, and the provider puts in like the specific orders for what diet they want the patient to follow at home, what activity they're allowed to do, any follow-up appointments that they have to have, then we print that out. That's called the AVS, or the after visit summary. It's their discharge papers and their plans. So a lot of you are reading those now in your nursing home patient, like so they've come from the hospital, and so that's what you see. So those, they'll have a couple pages that we print off and go through that with the patient, and they have to sign it. So we go through and make sure that they understand what the plan is for them when they go. All right, there's things called National Patient Safety Goals, and they have National Patient Safety Goals for nursing home, home care, hospital, all different areas, and they're updated every few years, and it's just like data that's collected, and it lets us know these are the main problems that we're seeing that are causing patient harm or patient concerns. So these need to be the main focus for your facilities. And once we get into the hospital, you'll see like posted all over, they'll have data on this, and they'll have like by their break room, they'll have all kinds of information hanging on the wall about like falls and how often their patients are getting bed sores or how quick their discharge turnaround is. And so they keep track of all these things to make sure that they're not causing patient harm. So since we're talking about medications, you'll see in that section here, there's 3 on using medication safely, just because we know that there's such a risk. So the first one there speaks to labeling medications. So when we're doing oral medications, they pretty much all come individually wrapped, so we don't have to worry about labeling them. Even our injections that we give, most of them really do come already drawn up, how we have to give them. It's just occasionally that we're gonna have to draw up a medication out of a vial, and the vial is what's labeled, so then now we have it in a syringe. So then we usually keep those together. We keep our vial with our syringe, and And then we also have to write out a label and put it on our syringe, just so we know it's the right drug. If we just have one drug that we drew up in one syringe, it's not as crazy, but if you have multiple syringes and multiple drugs like insulin and diuretics and pain medicine, which can occur, then for sure you wanna label all your drugs so that you're giving the right drug the right way and the right location. Okay, so it talks about labeling medication. So if you have to take it out of its labeled package, make sure we label stuff. The next one is about taking care for patients who take medications to thin their blood. So we've talked about this a little bit from the beginning. So because of all the cardiac conditions, we give patients medications to thin their blood so they don't have a heart attack or a stroke or anything like that. So because of that, they're automatically at risk for bleeding. Okay, so all those patients are on bleeding precautions. Okay, so you're gonna wanna know what bleeding precautions are. A main one is we educate them to use a soft toothbrush. Okay, it may sound like a weird thing to think about, but you probably will see it on a test one day, probably soon. So bleeding precautions are use a soft toothbrush, use an electric razor. They can't use a regular razor, it has to be an electric razor. Avoid trauma, seems like common sense, but if I asked you what are the bleeding precautions, I don't know that you would tell me avoid trauma. But they need to avoid trauma. And then the fourth one is that they need to monitor for signs of abnormal bleeding and bruising. So just be on the lookout. If you're having a bunch of bruises, if you're bleeding while you're brushing your teeth or anything like that, let us know. Okay, so those are bleeding precautions. Most of our patients are on blood thinners, so those are things that we should be thinking about for most of our patients. All right, and then the last one there is medication reconciliation. It just says record and pass along correct information about the patient's medications, find out what they're taking, compare it to new medications, give the patient written information, tell them it's important to keep that up-to-date list every time they go to the doctor. So when we give them that printout when they're discharged, we tell them to keep that with them so that if they get into trouble again, they have it. And then sometimes you'll have those patients who have like a duffel bag, they just bring all their pills with a label, a big duffel bag with all of them, and they say, this is this one, this one. So then we have to go through them all. All right, so those ones are the national patient safety goals specific to medications. The other ones that are focusing on are identifying patients correctly, so that's huge. We have to start at the beginning and make sure we're with the right person and we're gonna do what we're supposed to be doing to them. So using that name and date of birth with every patient interaction. Improving staff communication, speaking about getting important test results to the right staff person at the right time. So a lot of your facilities will have protocols and policies for critical labs. So if it's a critical lab value, usually the lab will have to call and talk to that nurse specifically, and then they have to document that they verbally let them know, and then the nurse has to document that they verbally talk to the provider about it. That would be important critical ones are like bleeding times, like we talked about with the Coumadin a little bit yesterday, the INR for Coumadin. So if their patient's blood is really, really thin and their INR is like sky high, that would be one. If their hemoglobin is crazy low and they need a blood transfusion, that would be one. And then like cardiac enzymes, some of you guys have seen in your patient charts about troponin. So troponin is thrown off when the heart is in distress, so it'll be elevated if there's like maybe heart attack. So that would be a critical one. And then like your potassium, if that's critically high or low, that would be one. So just a few examples. And then the last one there is about using alarms safely. So making improvements to ensure that alarms on medical equipment are heard and responded to on time. So depending on where you work, there might be a lot of equipment, a lot of alarms, and you might see people like silence them or dim them down. So it just talks about making sure that we don't do that inappropriately, because then we don't know what's going on with our patient. All right, so then if we do get busy or have a mistake and do give a patient a wrong medication, or even almost give a patient a wrong medication, we're supposed to fill out an incident report. So it's whoever is involved in it. So if you're the nurse or if you're the student, you'd be the one to fill this out. So it's just your name, your location, and this is just an example. They're all was it? So an accident of some type, like somebody fell maybe, I don't know what's different between an accident and an incident, but accident, incident, and near miss would be with medications. If there's violence, ill health would probably be like a visitor going down, and then a safety concern. Okay, so you're just gonna describe what happened, the outcome, the corrective measures. Okay, so this is just an example of an incident report, and then you would fill this out, and then it would go to your manager if you're employed, or it would go to the school if it happens as a student. Okay, but it's just to keep track of that, and then incident reports are not a part of a patient's medical chart. So it does not go in with the patient's chart, it's just for the facility. Right, and then some of your videos that you've gone through, there was just this example here from if your patient's taking digoxin and furosemide, and we've kind of gone through this scenario a little bit before with these medications, and it just speaks to when we're thinking about lowering their blood pressure or their pulse, being aware that we can do too much of a good thing, and we have to assess for that, make sure our vitals are okay to begin with and safe to give them. If they're already too low and we give those types of medications, then our patient's gonna fall. All right, now getting into the different routes of administration. So we're gonna talk about everything except IV, and then you guys are gonna get into IV first thing, second semester. Okay, so no matter what type of medication we're giving, there's some basic steps that we always have to follow for our patient to keep them safe and just to be doing it the right way. Okay, so first we need to verify all medication prescriptions and check for allergies. So as you log on and look at your patient's chart, running along the side is always gonna be their allergies. Before the system will let you administer medications, it makes you verify their allergies. So like something will pop up and prompt you, it'll say you haven't verified the patient's allergies, do you wanna do that now? Or if you don't wanna wait until it pops up, as you're in your patient's room, looking at their chart, looking at stuff, if you hover over the allergy list and you click on it, it'll say, do you wanna verify the allergies? And then you can. And all you do is ask the patient, you say, this is what's on your list, this is what it says happens, is that true, is that correct? Okay, and that's how you verify it, that's it. Say, is there anything new that is not on here that you wanna tell me? And then we can add that into the system. Okay, so once a shift, we have to verify and acknowledge if they have allergies. Okay, and then it's part of that last step as we're giving meds as well. Okay, as far as verifying the prescriptions, I talked about that process yesterday in the hospital, so how it gets written, and then the pharmacist looks at it, and then whoever is the RN during that time, you acknowledge them, but then after that, they're active and they're live. So it's just a matter of looking at your orders, okay? What's on your MAR comes from your orders, so it's gonna be the same thing. Back in the beginning of time, we had everything in a paper chart, all the orders were written there, and so we had to do like every 24 hours chart checks and go back and read through everything and make sure nothing was missed. But now it's a lot easier. Upholding the rights of MedAdmin before giving medications, okay, so you guys should have those memorized pretty well by now. So your patient, drug dose, rep time, reason, you have to have the MAR and a labeled drug to be doing a check, okay, and we do it 3 times. Hand hygiene is always the first step before we go operate the Omnicell and log in and get our medications. And then as we go into our patient's room, we always wash our hands again. Gloves, it just depends, right, on what kind of medication that we're giving. Just for any old regular, like a multivitamin, we don't need gloves for that. Aseptic technique in preparation and administration of all parenteral medications. So next week in lab, you guys are gonna practice with your syringes, right? With the hands on. You guys just take it one day at a time, not sure. But next week you should be starting to practice with them. Okay, so it just talks about, so like I said, some drugs come already pre-filled exactly how we need to give them. We don't need to do anything but open it, take off the cap and inject it. But sometimes we have to draw up medications. Sometimes the syringe and the needle are not all attached. Sometimes they're 2 pieces, so we have to take things apart. So it's just being aware that if we do have to take things apart and draw things up, that we only open it right before we're gonna use it. We don't like open things up and lay them all out because we wanna keep it clean or medically asepsis. We would never open a syringe and take a cap off of it and then set them down because now those areas are exposed. The end of the syringe always has to be covered with something. So if you're taking something off and switching out the needles, you have to have them ready and like do it immediately, not like take one off, set it down, think about it, look at your stuff, and then pick them back up. Because now that needle tip is contaminated because it has to maintain a closed system. Okay, so that's all that is really talking about, and you guys will practice that next week. Identifying your patient. So what are our two identifiers that we always use? Yeah, name and date of birth with our patient. We're gonna be using our barcode scanner in the hospital. Validating allergies, so again, just making sure these are your allergies, right? Or you have no known allergies, is that correct? And then always educating your patient about the medication. So again, this can be done at any time. It can be when you're doing assessment and data collection, or it can be like right before you go get your instructor to get the medications, or sometimes we wait and it happens when we're giving the medications. Okay, and it's nothing crazy. It's just like, this is metoprolol, it lowers your blood pressure, it can also affect your pulse, so we're gonna be watching those things, make sure you change position slowly. Okay, this is your multivitamin, it helps make sure you get the nutrition that you need. Okay, this is your Lasix, it's gonna lower your blood pressure, it's gonna make you go to the bathroom, we're gonna be watching your electrolytes because of it. This is your potassium, you're taking it because of that last one, because of your Lasix, because it can lower your potassium. Okay, so not a whole like mechanism of action and all that description, just basic, what's it for, what's it gonna do, and give them a chance first, because oftentimes they know that. Oftentimes they'll tell you exactly what it is, and then they did your work for you, and you can just say, yep, and move on to the next one. Alright, positioning them appropriately, so if we're giving oral medications, we need them sitting up as high as possibly possible so that they don't choke. Okay, and then make sure they're like wide awake, not like groggy and falling asleep, because we don't want our patient to choke. Okay, and then if we're giving topical medications, of course, we'll have to have access to the site, and then when we get to injections, we'll talk more about positioning for those injections. Okay, and then this whole big paragraph just talks about that we shouldn't open everything up in the med room and then carry it all around. We open it after the third check in the patient's room. Okay, so we make sure everything is correct and we have what we're supposed to have, and we open up last in the patient's room. Okay, we talked about never leaving medications at the bedside, especially in the hospital. Some of us have seen it in the nursing home, and we've talked about that. Like, it's a little bit different. If you're just looking at things black and white, is it okay? No, it's not. But if you're looking at things like there's a gray area, there can be some wiggle room there. Like if you know your patient and you know they're taking it and you stop back and check on them. Okay, but if it was just a yes or no, is it okay to do that? The answer would be no. And then it talks about documentation, making sure that things are documented before we leave. So there's been times at our nursing home that we've had like night nurses come back in because they forgot to sign off medications that they gave that night. So then now that day nurse is like, did the patient get the medications? What's going on? So importantly, of course, if you give meds, you need to document that you gave the med before you leave that room. And then the other things like a pain scale, blood pressure, those types of things. And then number 12 talks about keeping things separate if you need to. Again, things should be labeled so it's easy to find, and your system, as you're scanning things, will prompt you. Like if one of your pills comes as 50 milligrams and your patient gets 25, when you scan it, doing your third check, it'll tell you. It'll say you scanned 50, it's supposed to be 25. So it'll tell you right there, and then you'll have your pill cutter, you can cut it, and you're good to go. But it's not a bad idea to keep things separate. Like maybe your patient's blood pressure and pulse have been really unstable and you've been checking it very frequently and you're not sure if they're gonna get this cardiac med, maybe you have it set aside. All right, and then number 13 talks about 30 minutes after giving these medications, if there is gonna be an effect, like blood pressure, like pain, to go back and reassess and document that. And then always updating our provider if there's any concerns or problems giving the medications. If we have to hold something, or if a patient doesn't wanna take something, or thinks they're allergic to something, anytime there's a concern or problem, we can follow up with them. All right, some questions. Alright, your best choice then is C, medication prescription and client allergies. Okay, so that just means there's an order for it and they're not allergic to it, right? The other things, expiration date, yeah, you wanna make sure your drug's not expired. Again, in the hospital, you're not gonna have a drug that's expired, because it's checked by so many people. But for your checkoff, that is one of the things you're gonna say, is that it shouldn't be expired. But we don't stop and check the patient's insurance before we give meds. Okay, the medication rights, we do right before we give meds, but we don't go look at the provider's signature every time we give meds. Okay, and then medication packaging and dosage cup cleanliness is not something that we're checking each time. And as you read through, C should jump out at you, two identifiers, name and date of birth. Okay, and then just some vocab, so unit dose means that's the individually packaged medications. Multi-dose would be like a big bottle of pills. See? Okay, so they should not be opened until after our last check, after we scan and everything matches, and we know that for sure we're gonna give them. And discard it. It says clean container, it doesn't say like locked container. So we didn't talk about this option. The option that we talked about is not on here. It does kind of sound like C, so that was a little bit confusing. But yeah, if we have to suddenly leave and there's no place to lock them up, then we have to discard them. Alright, this one's gonna be C, a multi-dose vial med drawn into a syringe or cup. Okay, so let's go through, so A, a prepackaged unit dose is our single unit dose, so that's labeled, so we don't have to worry about that. Liquid oral meds poured at bedside, so if we're at the bedside now, then we're on to our third check. So we've already done everything, and we're right there about to give it, so we're okay there. Multi-dose vial means drawn into a syringe or a cup. A syringe would be example to explain, so it'd be like an IV drug. So if you have like a large vial of medication that you can pull multiple doses out of, so it's a multi-dose vial, so you can go in and out of it multiple times to get what you need, so it would stay locked in the med room, and then once it's empty, they would discard it. So if we did that, then we'd have to label that syringe. Okay, IV push meds from a single-use ampule. If it's single use, then we're just gonna take that with us, and then, it's different from a multi-dose. Okay, good. So your best choice is D. Immediately after administering the medication, document any pertinent client information at the bedside. Alright, that should be D, to just recognize that they might need a specific assessment, so we might not give it, it depends on what data that we're gonna collect. Yeah, within 30 minutes is when they should be reassessed. We'll do one more question, then we'll take a break.